So today we'll get started with cardiology. So let's get started with the fetal circulation. Once you get an idea of this, the congenital heart defects and all those things becomes easier. So the major difference from an adult circulation and a fetal circulation is that in fetal circulation, lungs doesn't play a major role. It is the placenta where the gas exchange and nutrient exchange and the waste removal, everything takes place. So the placenta carries blood to the heart, okay, and that is via the umbilical vein. Umbilical vein. Now, if you're getting confused with umbilical vein or umbilical artery, you have to remember that vein is anything that carries blood to the heart. Like you have IVC, you have pulmonary vein, you have umbilical vein. So it is anything that carries blood to the heart. Okay, it is not based on whether it is oxygenated or deoxygenated. It is based on whether it is carrying blood to the heart or from the heart. To the heart is always vein. So it is umbilical vein which is carrying blood to the heart, and we have only one umbilical vein. And you can remember it like left umbilical vein is left behind. So it is the left umbilical vein which is left behind, and we have left umbilical vein which is carrying the blood to the heart. And finally the blood is taken up back to the placenta for oxygenation via the umbilical arteries. So you can remember, like artery, it is taking blood away from the heart to the placenta. Okay, so along the course, umbilical vein carries blood to the IVC. Okay, now when it is taking blood to the IVC, there is another bypass mechanism which is called the ductus venosus. What is it doing is, this umbilical vein has oxygenated blood which is rich in oxygen. Now you have to make sure that most of this oxygenated blood doesn't get mixed with the portal vein and the deoxygenated blood from the portal vein. So that is why you are having a bypass mechanism, which is the ductus venosus. So it is taking this blood to the IVC via ductus venosus. So most of the oxygenated blood goes like that without getting mixed with the deoxygenated blood from the portal vein. So IVC is carrying blood to the heart. So is SVC carrying blood from the head and upper parts to the heart. Now, just like your adult circulation, you have the right atrium, you have the right ventricle, and you have the left atrium and the left ventricle. So from the right atrium, it goes to the right ventricle. Now there is a major difference here as well, because the atria is connected with each other by a foramen ovale. Most of the oxygenated blood, so here it is like this, from the umbilical vein via the ductus venosus, it is getting into the IVC. IVC, it is going into the right atrium, and it is taken in such a way that most of the oxygenated blood will get shunted to the left atrium. Okay, and the blood from the SVC, which is mostly deoxygenated, go to the right ventricle. So mostly like that. So it minimizes the mixing so that mostly oxygenated blood reaches the left atrium by foramen ovale. So this is another extra connection that is there in the fetus. We have a ductus venosus, we have the foramen ovale. So as in adults, from the right ventricle it goes through the pulmonary artery to the lungs. Okay, and from the left atrium it reaches the left ventricle and it goes to the aorta, okay, to supply the other body parts, and finally by the umbilical artery back to the placenta to get it oxygenated. Okay, now here is another uh, mechanism wherein most of the blood from the pulmonary artery is taken to the aorta, to the descending aorta by ductus arteriosus, because there is no major role for lungs. The pulmonary pressure is very high, so the major blood is not going to the lungs because lungs has no role in oxygenation. So even if you're taking blood to the lungs, it's not going to be useful. So majority of the blood goes to the aorta by ductus arteriosus. So these are the three extra connections that you have: ductus venosus, umbilical vein to IVC, foramen ovale between the right and left atria, ductus arteriosus between the pulmonary artery and descending aorta. So oxygenated blood from the placenta goes by umbilical vein, shunted into IBC by ductus venosus, goes to the right atrium. Majority of the oxygenated blood through foramen ovale reaches the left atrium, then to the left ventricle and to aorta. So this oxygenated blood is mainly taken to brain and myocardium and other upper extremities. Now the deoxygenated blood returns via SVC to the right atrium. So I told you it's done in such a way that majority of oxygenated blood that is reaching the right atrium is transferred to the left atrium by foramen ovale, and majority of deoxygenated blood is going by SVC to right atrium and then to the left right ventricle. 1/3 of blood entering right atrium does not flow through foramen ovale, which is mostly deoxygenated, which goes to right ventricle and then to pulmonary arteries. And in the pulmonary artery also, it is not going mainly to lungs, but it is getting transferred to the aorta by ductus arteriosus. That is your systemic circulation. Finally, it reaches the placenta for reoxygenation via the umbilical arteries. Okay, now we have three openings. Now they have to close at birth, because in adult circulation we don't have that. So in fetal circulation, another main difference is right ventricle is having a higher pressure than left ventricle. Okay, because the pulmonary vasculature pressure is very high, so the right sided pressure is more than the left sided pressure. Also, it has to allow blood to flow through the foramen ovale from the right to left, so right sided pressure is higher. But as soon as the child is born and they take their first breath or they cry, the lungs started acting, the lungs expand and there is oxygenation, so the pulmonary vascular pressure decreases. So there is more blood flowing to the lungs, and eventually the right sided pressure falls and left sided pressure takes up, and you have all the extra openings closing. That is your foramen ovale, ductus arteriosus, ductus venosus. So what happens is, with the first breath the lungs open up, the pulmonary resistance decreases and pulmonary blood flow increases. So there is a separation of low resistance placenta to systemic circulation, becoming a high resistance system. So your ductus venosus first closes. Ductus venosus closes. Due to increased pulmonary flow, there is increase in left atrial pressure, because more blood is reaching back to the left atrium via the pulmonary vein. And so foramen ovale closes, because I told you in fetus right sided pressure is higher, but in adult, as soon as the child is born, the left sided pressure eventually builds up and foramen ovale closes. Increased oxygen concentration in blood after first breath, that decreases the prostaglandins, and ductus arteriosus also closes. So ductus venosus, then foramen ovale, ductus arteriosus. Now closure of fetal shunts and change in vascular resistance. Finally, the infant circulation assumes normal adult flow. Okay, so there is a two drug which can alter this mechanism, mainly at the ductus arteriosus level. So you can maintain the fetal pathway open by the prostaglandins, because I told you increase oxygen concentration in blood after first breath decreases the prostaglandin. That is why your ductus arteriosus is closing. So if you are giving prostaglandins like PGE1, you can maintain the opening of ductus arteriosus, which may be necessary for survival in some patients, which is a duct dependent system. We'll discuss that later. So in that you may have to give prostaglandin. In such cases indomethacin will be contraindicated also, because indomethacin is a drug which can reduce prostaglandin and can fasten the closure of ductus arteriosus. So your ductus venosus is closing, foramen ovale is closing, ductus arteriosus is closing. So it changes after birth. At how is the closing of shunts and what is the remnant of each of that. So when the ductus arteriosus closes within 10 to 96 after birth, there is something called functional closure and anatomical closure. Functional closure means there is no flow through that. okay, due to change in pressure. Anatomical closure means actual closure. That happens 2 to 3 weeks after birth, and it becomes the ligamentum arteriosus. So your ductus venosus become your ligamentum venosum again several minutes after birth. That is the first thing to close, okay? And 3 to 7 days after birth is your anatomical closure. For Raman ovale, again several minutes after birth, but anatomical closure happens a bit later. That is why even if you are having a patent for Raman ovale, you can wait for some time because mostly they spontaneously closes in one to 1.5 years and becomes a fossa ovalis. Your umbilical arteries can become umbilical ligaments, umbilical vein becomes ligamentum teres. Now, coming to congenital heart diseases, you are classifying that based on the presence of cyanosis. So, you can have cyanotic heart diseases or acyanotic heart diseases. Acyanotic heart diseases are mainly your VSD, ASD, and PDA. Okay, or atrioventricular septal defect or endocardial cushion defect. Okay, which is what you're having in Down syndrome and all. In that mainly you are having a left to right shunt because as the child is born, the left sided pressure takes up. So when there is a gap or a connection between the right and left system, mostly the blood starts to go from left to right side. Or you can have obstructive lesions without cyanosis like coarctation of aorta, aortic stenosis, or pulmonic stenosis. Now, cyanotic lesions you can remember like 5T, which is TOF, okay, or TGA, that is transposition of great vessel, truncus arteriosus, total anomalous pulmonary venous drainage, tricuspid atresia, hypoplastic left heart syndrome. I think you have to know all of this name. You have to know what is happening in each of this. So we have a right atrium, we have a left atrium, we have a right ventricle, and we have a left ventricle. Okay. So what is ASD? It is atrial septal defect between the two atria, and there is blood flowing from left to right. What is ventricular septal defect? That is between the two ventricles. It can be a small defect or a large defect. In small defects, you have intensive murmur. As the defect becomes larger, the flow through that murmur becomes less audible. Flow through that defect becomes less audible, so you have a low intensity murmur. So that is your VSD. PDA means, like I told, you have a ductus arteriosus, which is actually connecting your pulmonary artery with the descending aorta. There was a connection. So if that is persisting, that is called the PDA. Again, there can be a left to right shunt with that, or atrioventricular septal defect or endocardial cushion defect. Now, coarctation of aorta, it is usually at the site where the ductus arteriosus is joining the aorta, or there can be aortic stenosis or pulmonic stenosis. Now, what is TOF? It is tetralogy of Fallot. There are 4 things in TOF, which we'll discuss later. Now, what is Epstein's anomaly? Epstein's anomaly is, so you have a right atrium, you have a left atrium, okay, you have a right ventricle and you have a left ventricle. So what is happening in Epstein's anomaly is, I'll draw this nicely. So what is happening in Epstein's anomaly is, usually you have this right atrium like this and right ventricle like this, okay, and the right sided valve, what is it called? Tricuspid valve. Okay, usually the tricuspid valve will be situated here, but what happens in Epstein's anomaly is tricuspid will be situated a little bit down, okay, like here. So this much area will be your right atrium, and only small will be your right ventricle. So that is called atrialization of ventricle. Atrialization of ventricle. So most of the part of the ventricle, actual ventricle, is becoming atria because tricuspid has been pushed a little bit down. So that is called Epstein's anomaly, commonly associated with in utero exposure of lithium. So this is important. In utero exposure of lithium leads to Epstein's anomaly. It is a cyanotic heart disease. Okay, and you also have transposition of great arteries. So that means your great arteries are pulmonary artery and aorta. So usually the right ventricle opens to pulmonary artery. The left ventricle opens to aorta. But here what is happening is there is a defect. So right ventricle opens to aorta. Right ventricle opens to aorta and left ventricle opens to pulmonary artery. Pulmonary artery. So what happens? You think about it. What happens? The SPC and IVC is taking blood to the heart, to the right side of the heart. Right side of the heart, it is going to right ventricle. It has to actually go to the pulmonary artery to the lungs for oxygenation. But now what is happening is the right atrium, right ventricle opens to aorta. So that deoxygenated blood will reach us the body. Okay, now what happens in the left side? Left side, the lungs will have blood taken via the pulmonary vein to the left atrium and then to the left ventricle, but left ventricle, which has to actually open to aorta, now opens to pulmonary artery, which is taking blood uh, back to the lungs. So that is called this transposition of great arteries can be called a parallel circulation. That means systemic circulation and uh, pulmonary circulation, they are not meeting somewhere. So in order for the child to survive, there has to be another opening which is connecting these two systems, so that there is some mixing of oxygenated and deoxygenated blood and some oxygenation which is happening. So that is for TGA and all, you have to maintain the ductus arteriosus, that is called duct dependent system. You may have to give PG even for those children. So that is called a duct dependent system. TGA is called a parallel circulation because the systemic and pulmonary circulation without any extra connection will be independent of each other, and that will not be fit for survival. So usually they have ductus arteriosus, and you have to maintain that open until surgical correction can be done. You have to switch the arterial system, that is called arterial switching. Now what is truncus arteriosus? Truncus arteriosus means the aorta and pulmonary artery originates from a common thing, that is called truncus arteriosus. Again, there is mixing and there is cyanosis. Total anomalous pulmonary venous drainage. That means the pulmonary vein is draining incorrectly. It's not draining to left atrium, which it normally should, but it is draining somewhere else. That is called TAPVC or TAPV. S, like a pulmonary venous system or a drainage. That's called total anomalous pulmonary venous drainage. Then tricuspid atresia. Tricuspid atresia, there will be, when there is tricuspid atresia, blood cannot reach the right side, so it cannot reach the pulmonary, so there cannot be oxygenation. So again, for the survival, they will need some other mechanism so that there is mixing of blood and there is some oxygenation. Hypoplastic left heart syndrome is when the left side of the heart is hypoplastic. So you have to do some surgery to correct that. One of that procedure is called Fontan procedure. This is actually a 3-step procedure. We will discuss all of that. You just have to get the names correct. Okay, because it can be a little bit confusing, but once you know the mechanism, it becomes easier. So TOF is tetralogy of Fallot. You have 4 things in that. We'll discuss that. Epstein's anomaly is atrialization of ventricle, which is usually associated with in utero exposure of lithium. TJ is transposition of great arteries, where the pulmonary and aorta is incorrectly positioned. Pulmonary artery originates from the left ventricle and aorta from the right. So there is a parallel circulation for the survival. There has to be some other extra connection, so you may have to keep the duct open by PGE1. Truncus arteriosus, when you have a common opening for the aorta and pulmonary artery. Total anomalous pulmonary venous drainage, when the pulmonary vein is draining not to the left atrium but to some other site. Tricuspid atresia, when you are having atresia of the tricuspid valve. Hypoplastic left heart syndrome, when the left ventricle is not fully developed. So they all need surgical correction whatsoever. Okay, ASD, BSD, PDA may not be that severe because there is a left to right shunt, there is cyanotic heart disease. They may need correction based on the symptoms and all of those things. BSD, if it is very small, it can close spontaneously also. So cyanosis is bluish discoloration of mucous membrane, nail beds, and skin secondary to an absolute concentration of deoxygenated hemoglobin of at least 30 gram per deciliter. Okay, ASD is atrial septal defect. So there is fixed split of second heart sound usually in ASD and VSD. ASD can be different type. It is called ostium primum and ostium secundum. Now this is based on the developmental thing. So there is an ostium primum which is coming, ostium secundum which is coming. Okay, that is how you are having this foramen ovale and the closure and all. So it is ostium primum type and ostium secundum type. Ostium secundum is the most common type. Okay, but if in some question if they ask what is a common type of ASD, you have to say ostium secundum. But if they may ask what is the most common type of heart defect, okay, and they in options you have ostium primum, ostium secundum, ASD. Along with that, you have also foramen ovale, patent foramen ovale. Then you have to say it is patent foramen ovale. Okay. Now both ASD and VSD are associated with RBBB, right bundle branch block. But in ostium primum, not ASD and VSD, both type of ASD, that is ostium primum type and ostium secundum type, are associated with RBBB. But ostium primum is associated with left axis deviation. Secundum is associated with right axis deviation. Okay, less than 8 mm, they can go in for spontaneous closure. Definitive diagnosis is with cardiac catheterization, but the initial assessment can be with echo. Now, VSD, it is the most common congenital heart defect. Most common congenital heart defect is VSD. Most common among ASD becomes secondum type of ASD. There can be hollow systolic murmur at the left lower sternal border, mid-diastolic rumble at the apex. Okay. Mid-diastolic rumble is mainly because there is a VSD, there is a connection between the ventricles, so the blood is flowing and it is hitting the valve. Maybe that is why we are having a mid-diastolic rumble. Then size of VSD is inversely related to intensity of murmur. That's what I told. If it is a small defect, the murmur can be loud. So if it is a loud murmur, it may be a good sign. Loss of splitting of second heart sound and loud P2 suggest pulmonary hypertension. So when you have VSD, so you are having too much flow through the pulmonary artery. Okay, so there are two kinds of pulmonary hypertension. You know, there is an obstructive pulmonary hypertension which can happen with pulmonary stenosis and all, and there is also like a flow related pulmonary hypertension which is due to the excess flow. So that can lead to pulmonary hypertension. And pulmonary hypertension, you can have loud P2 and loss of splitting of second heart sound. Okay, actually there is splitting, maybe fixed splitting, but now there can be loss of splitting. In BSD, AAC inhibitor can have an effect because it can reduce the systemic vascular resistance and then increases the flow through LVOT, left ventricular outflow tract, because usually the major blood is coming through the defect and it is going to the pulmonary artery. So if you're giving AC inhibitor, what it does is it reduces the systemic vascular resistance. So you can increase the flow through the left ventricular outflow tract. Digoxin and diuretics also have a role. Now, PDA is patent ductus arteriosus, another acyanotic congenital heart disease. It is actually a normal finding in the first 12 hours of life because we told it takes time for the ductus arteriosus to close. But it is pathological if it persists even beyond 24 hours, and it is a common defect associated with congenital rubella. Now, in PDA, you can have a heavy machinery murmur. Okay, heavy machinery murmur with a high pulse rate, wide pulse pressure, hyperactive precordium and big bounding pulse. Okay, it is a connection, persistent connection between the pulmonary artery and aorta. Now, coarctation of aorta, it is most commonly associated with bicuspid aortic valve. Turner's is associated with bicuspid aortic valve, so Turner is also having higher incidence of coarctation of aorta. You can give prostaglandins to keep the PDA open until surgery. So this is rib notching, which is seen in coarctation of aorta. Okay. Aortic stenosis and pulmonary stenosis. Aortic stenosis can be four types: valvular, subvalvular, supravalvular, and idiopathic hypertrophic subaortic stenosis. You have to know that valvular is the most common type. Pulmonary stenosis is three types: valvular, subvalvular, and supravalvular. The valvular type again is the most common type, and it is associated with TOF or with Noonan and congenital rubella. Now coming to cyanotic heart diseases, which is your TOF. TOF means tetralogy of Fallot, which means there are four things happening. So one is a large VST, okay. Next one is a pulmonary stenosis. Next is an aorta overriding the defect. And fourth one is right ventricular hypertrophy. So VST, right ventricular outflow tract obstruction or your pulmonary stenosis, aortic root overriding the ventricular septal defect, and right ventricular hypertrophy. So infants may initially have a left to right shunt, and therefore they may not have cyanosis. But as the pulmonary stenosis become progressive, they lead to right to left shunt with hypoxemia and cyanosis. Okay, initially because the left-sided pressure is higher, there can be a left to right shunt, but when the pulmonary stenosis becomes severe, there is reversal of shunt and cyanosis. Degree of right ventricular outflow tract obstruction determines the direction and degree of shunt associated with the thing. Now, the classical history in usually given in exams with TOF is the hypoxic or TET spells. What is happening during exertional state, like crying or exercise? There is increase in pulmonary vascular resistance. Okay, so there is decrease in systemic resistance, which causes an increase in right to left shunting. So there is increase in cyanosis because of right to left shunting. So there is increase. The features can include paroxysm of rapid and deep breathing, irritability and crying because of hypoxemia and cyanosis, and there is increase in cyanosis with decreased intensity of murmur because of there is decreased flow across the right ventricular outflow tract obstruction or the pulmonary valve, and there is a large VST, so the murmur is usually reduced in intensity during these spells. And the patient will squat for relief. So this is classical of this. And the treatment also includes knee chest position because that can increase the peripheral resistance and decrease the right to left shunting. So management of spells is to give oxygen because they are in hypoxia, knee chest position, fluid bolus, morphine sulfate, and propranolol. Okay, oxygen, knee chest position, fluid bolus, you can give morphine sulfate and propranolol. Best initial treatment is PGE1 to keep the PDA open, along with urgent surgical consultation. TET spells can treat with oxygen, propranolol, phenylephrine, knee chest position, fluids, and morphine. Temporary palliation can be achieved through creation of an artificial shunt that is called a balloon atrial septotomy before definitive surgical correction. That is a Blalock Taussig shunt. It's a temporary correction before the actual procedure. Now TGA, that is transposition of great vessel, it is the most common cyanotic heart disease of newborn. But tetralogy of Fallot is the most common cyanotic heart disease of childhood. Why? Because the TOF may not present as soon as the child is born. It may take some time for the TOF to present. But transposition of great vessel is the most common cyanotic heart disease in newborn. Okay, so if the question mentions cyanosis in newborn, the most common cause is transposition of great arteries, wherein the pulmonary artery is originating from the left side and aorta from the right side. So it is usually a parallel circulation unless and until there is another connection which is connecting these two systems, the child will not survive. Survival is dependent on mixing either through PDA, AST or VST. In X-ray, you have egg on string appearance. In TOF, you have a boot-shaped heart, okay? In TGA, you have egg on string appearance. Symptomatic neonates, you can give PG1 to keep the PDA open until balloon atrial septostomy. Surgical repair is the arterial switch performed in the first 2 weeks in those without a VST, while LV muscle is still strong. Then truncus arteriosus. It is a single great vessel which gives rise to aorta, pulmonary and coronary artery. Okay, and the truncal valve overlies a large VST. Potential for coronary ischemia with fallen pulmonary vascular resistance. Management is surgical repair within the first 6 weeks to prevent pulmonary hypertension. That is the most common sequelae of truncus arteriosus. Then Epstein's anomaly, that is the septal and posterior leaflets of tricuspid is malformed and displaced into right ventricle. So there is atrialization of right ventricle. Potential for RV dysfunction, tricuspid stenosis, tricuspid regurgitation. So there can be valvular defects or functional pulmonary atresia if RV is unable to open pulmonic valves. Usually it is associated with conduction, accessory conduction pathways like Wolff-Parkinson-White WPW syndrome, wherein there is an accessory pathway between the atria and ventricle. It may be associated with maternal lithium exposure or benzodiazepine use in the first trimester. In newborns, closure of tricuspid valve with aortopulmonary shunt or transplantation. In older children, you can repair the valve or valve replacement with ASD closure. So chest X-ray findings in tetralogy of Fallot is boot-shaped heart. Egg-shaped heart is seen in transposition of great vessel. Snowman heart is seen in total anomalous pulmonary venous return. Okay, that is Snowman or 8 sign. Now, hypoplastic left heart syndrome. Therein you have a single S2. There is gray cyanosis. It is less blue and more gray. Initial test is chest X-ray. You can see a globular heart with pulmonary edema. Best diagnosis is echo. It is a 3-step surgery with procedures named Norwood, Glenn, and Fontaine. Okay, this is the hypoplastic left heart syndrome. The left ventricle is it is not even there, right? So stage 1 palliation with the Blalock-Taussig shunt. Okay, then you give other shunts, and finally the procedure is Fontaine procedure. It's actually a 3-step procedure. The tricuspid atresia. When there is a tricuspid atresia, the blood will not move to the right ventricle. So there is complete mixing. All systemic venous flow must cross the atrial septal defect because it cannot go to the right ventricle. So it is going to the left atrium by this atrial septal defect. All pulmonary blood flow must cross the VSD or go through patent ductus arteriosus. Okay, so that it can reach the aorta. We need a systemic to pulmonary artery shunt because the blood is not going through the pulmonary artery mainly. Eventually, we'll need a single ventricle palliation. Blalock-Taussig shunt for tricuspid atresia, wherein you are shunting the blood from the subclavian artery to the pulmonary artery with an interposition graft, which increases the pulmonary blood flow and increases systemic saturation. Now, these are certain congenital heart defects and associations. ASD and endocardial cushion defects with Downs. PDI mainly with congenital rubella. Coarctation of aorta, bicuspid aortic valve with Turner syndrome. Coronary artery aneurysm is seen with Kawasaki disease. That is why you are giving aspirin and IVIG to those children who are diagnosed with Kawasaki. Neonatal lupus with congenital heart block, and the antibody associated is anti-Rho antibody that is associated with neonatal lupus causing congenital heart defect. Williams syndrome with supravalvular aortic stenosis, cornotruncal abnormalities like TOF, overriding aorta, truncus arteriosus, DiGeorge again can have TOF, velocardiofacial syndrome. Epstein's anomaly with maternal lithium use, heart failure, neonatal thyrotoxicosis, asymmetrical septal hypertrophy with maternal diabetes, and transposition of great vessels also. Now, 4 key features of uh, congestive heart failure. You have tachycardia, tachypnea, cardiomegaly, and hepatomegaly. Now, another important topic is acute rheumatic fever. So, acute rheumatic fever is associated with the previous group A streptococcus pharyngitis or tonsillitis without antibiotic treatment. Usually, the affected age group is 5 to 15 years. So there is an evidence of previous streptococcal infection either by a throat culture or an ASO titer or a rapid antigen detection test, okay, or an anti-streptococcal DNA B test. Treatment is antibiotic treatment of underlying group A streptococcal infection, symptomatic treatment for arthritis and fever. Now it has several constituents, and you have to know the criteria for diagnosis as well. It can have fever, malaise and fatigue with valvulitis and pancreatitis, skin manifestations like erythema marginatum, subcutaneous nodules, and arthritis or arthralgia. Arthritis is mainly migratory polyarthritis. There is Sydenham's chorea with jerking or flinching movements, usually 1 to 8 months after the infection. So the disease causes, there is an untreated streptococcal pharyngitis or tonsillitis. So there is development of antibodies. Due to molecular mimicry, it also affects the heart muscles and other things. That is why it is a type 2 hypersensitivity reaction, which is an antigen antibody interaction with inflammation and cell damage, which is causing the rheumatic fever. So the criteria is called John's criteria. You can remember it like Cafe Pal, or you can remember it like John's. John's for major criteria, Cafe Pal for minor criteria. So John's. So J for joint involvement, which is the arthritis, migratory polyarthritis, which is in the major criteria. In minor criteria, you have arthralgia, which is just pain. O means O, you can write it like heart. Okay, so there is a pancreatitis or myocarditis. Pancreatitis means myocarditis, pericarditis, and endocarditis. It can be myocarditis or pancreatitis. Then subcutaneous nodules, N for subcutaneous nodules. E for erythema marginatum, which is again a skin manifestation. Sydenham chorea. Okay, minor criteria includes raised CRP and raised ESR, fever, arthralgia. Then prolonged PR interval, amnesia of rheumatism and leukocytosis. For diagnosis, you need 2 major criteria or 1 major plus 2 minor criteria along with evidence of streptococcal infection either by an ASO titer or a throat culture. Okay, so that is rheumatic fever. Now, for rheumatic fever, you give secondary prophylaxis with penicillin. So how long you have to give this secondary prophylaxis? You have to give for rheumatic fever without carditis, you have to give for 5 years or until 21 years of age, whichever is longer. So suppose if the patient is 17 years maybe. So you have to give until 22 years because whichever is longer. So you have to give for 5 years. Now rheumatic fever with carditis but no residual disease, you can give for 10 years or 21 years of age, whichever is longer. With carditis and residual heart disease, you have to give until the age of 40 years or lifetime prophylaxis may be needed. Most common valvular association associated with rheumatic fever is mitral stenosis. Now coming to infective endocarditis. Infective endocarditis means it is inflammation of the endocardium of the heart. So mainly there is fever and there are other signs wherein you suspect infective endocarditis. The most common organism in adult and children is Staph aureus. Okay, but in children with underlying heart disease, there can be Streptococcus viridans. Okay, and there are other causes of infective endocarditis like Streptococcus bovis or Agalactiae and Streptococcus Staph epidermidis. Okay, now these are seen with in different conditions. Mainly Staph epidermidis is seen with this valve replacement. Post valve replacement in early period, it is epidermidis valve replacement. Bovis is associated with colon cancer. So if in an adult, mainly in adults, okay, these are in adults. In adult, if you find infective endocarditis and the causative organism is found to be Streptococcus bovis, you have to always do a colonoscopy because you have to rule out colon cancer. But in children, the most common organism is Staph aureus. In children with underlying heart disease, it can be Streptococcus viridans also. First line empirical treatment for native valve is vancomycin plus gentamicin or ceftriaxone. First line for prosthetic valve is vancomycin plus gentamicin plus rifampicin. Clinical features are fever, road spot, there are Osler's nodes, there can be murmur, Janeway lesions, anemia, nail bed hemorrhages, which are called splinter hemorrhages, and embolization phenomena. Okay, so these are our different skin manifestations like Osler node, splinter hemorrhage like in nail bed hemorrhage. They are skin manifestations, Janeway lesion, road spot, all. Okay, this again showing different manifestation of infective endocarditis. Road spot is retinal hemorrhages with small clear centers. Okay, splinter hemorrhages are subungual or under the nail bed. Dark red linear lesions in the nail bed. Janeway lesions are non-tender macules in the palms and soles. Osler nodes are painful nodules in the palps of finger. Okay. Then there can be pericardial rub or pleural friction rub. There can be arrhythmias, okay, conjunctival hemorrhage, embolization phenomena, okay, and there can be splenomegaly and all. This is the normal heart rate in an infant of at birth to 11 months. It is 110 to 160. Then it comes down. 12 months to 2 years is 100 to 150. 2 years to 5 years is 95 to 140. 5 years to 11 years is 80 to 120. Then adult that is 60 to 100. So in infants, their normal heart rate itself is a little bit higher. Now pulses, these are different types of pulses. Pulses alternans is a sign of left ventricular systolic dysfunction. Bigeminous is a sign of hypertrophic obstructive cardiomyopathy. Dysperience is an aortic regurgitation where there is a uh, bifid or two peak in the systole. Pulses parvus et tardus is aortic stenosis is a slow rising pulse. Pulsus paradoxus is in cardiac tamponade and tension pneumo. Irregular is seen in atrial fibrillation. Now, heart murmurs. There are innocent murmurs and pathological murmurs. Innocent murmurs, they are different M. Soft, usually systolic. Okay, there is a physiologic S2. It is positional. Okay, that is the murmur varies with position. There are no extra sounds, usually asymptomatic. Okay, so that is innocent murmur. Asymptomatic, systolic, soft, a physiological S2, and it varies with position. Pathological, any diastolic murmur is always pathological. Okay, and there are signs of cardiac disease like failure to thrive or exercise intolerance, or a pansystolic murmur, again pathological. Continuous murmur, pathological. A palpable thrill and harsh murmur with fixed split or single S2. Okay, but no change with position. That's a pathological murmur. Now, usually mitral murmurs radiate to the axilla, tricuspid and pulmonary radiate to the back, and aortic radiate to the neck. Now, there is a difference between the pediatric ECG axis and the adult ECG. There are certain differences where pediatric heart rate is usually higher, like we have seen. There is a shorter PR and QT interval and QRS duration. There is inferior and lateral small Q waves that are not pathological. RV is larger than LV in neonates. So there is normally there is a right axis deviation. That is why in adults our normal axis is minus 30 to plus 90. Minus 30 to plus 90, but in pediatrics there is a little bit right axis deviation, so they have 90 to 180. Axis is a bit deviated to right. Large precordial R waves, upright T waves. Okay, you don't need to know all of these things. You have to know there is right heart is a little bit right ventricle is a bit larger than left ventricle, and there is usually the heart rate is higher. Now, talking about sudden cardiac death, there can be different reasons for sudden cardiac death. One of them is a long QT syndrome. You can have congenital syndromes also, like Brugada, okay, or hypertrophic cardiomyopathy. Again, can be a cause of sudden cardiac death, but mainly in uh, adolescent to adulthood. Long QT, it can present with syncope, hearing loss, and normal vitals. Treatment is with beta blocker like metoprolol, and then definitive treatment is ICD. ICD is implantable cardioverter defibrillator. Okay, but sotalol can increase QT. Though it is a beta blocker, you cannot use it for long QT because it can again uh, increase QT. There is something else called sudden infant death syndrome, SIDS. Okay, so what are the things that you can prevent? To you can do to prevent and protect the child from SIDS. Usually it is before 1 year of age. The child, there is usually during their sleep they die, and there cannot be any cause attributed. So you can prevent these things by certain precautions. You can use a blanket. Never use loose blankets because they may put it over their face, and they may suffocate and choke and die. Once breastfeeding is established uh, after a pacifier, keep baby in mom's room, not in a separate sleeping area. There should not be more than a soda can width between the bars because the child may go out. Do not overclothe the baby while sleeping. The baby should not be hot to touch. Use a firm mattress, no soft bedding. Remove everything other than the mattress and the sheet. No toys. Keep a smoke-free zone around the baby. Always place the baby on the back to sleep. Ensure the crib is properly assembled. So these are things you can try to protect the child from SIDS. Now, what is fetal alcohol spectrum disorder? Fetal alcohol spectrum includes fetal alcohol syndrome, partial FAS, alcohol-related brain damage, and alcohol-related neurodevelopmental disorder. What are the criteria for diagnosis? Growth deficiency, low birth weight, or decelerating weight over time, not due to nutrition related thing. Characteristic pattern of facial anomalies like short palpebral fissure, flattened philtrum, thin upper lip. Having all three features is highly specific for alcohol exposure. CNS dysfunction need three of the following, like motor skills, neuroanatomy, neurophysiology, cognition, language, academic, memory, attention, etc. etc. Okay, so this is fetal alcohol syndrome. Now, for alcohol-related brain damage, congenital anomalies including malformation, dysplasia of cardiac, skeletal, renal, ocular, auditory, etc. Neurodevelopmental disorder, similar to fetal alcohol syndrome, CNS dysfunction will be there. But it is inconsistent with development level that cannot be explained by familial background or environment alone. Okay, that's all in the cardiology session.